Unhappy with previous lower blepharoplasty. Will skin grafts be effective in correcting my case? What are the complications? 2 years ago, lower blepharoplasty was performed. Now, lower eyelid retraction. One surgeon proposed to use skin graft. Questions. Will the skin grafts be effective in my case? How often do the skin grafts usually wrinkle, scarring, after operation? What are the complications that usually occur after transplantation of skin grafts? The main point of skin grafts is a plus tissue. That means after operation, the weight of lower eyelids increases. Does it mean that lower eyelids will pull down?
Thank you for your question. You've submitted a question with two photos, what appears to be a before and after you had undergone lower eyelid blepharoplasty approximately 2 years ago. And you state in your question that you've developed lower eyelid retraction and that you've gone to a doctor who recommended a skin graft procedure. And you've asked several questions related to the appearance, the healing, the wrinkles, as well as the weight of the skin graft after this surgery. Well, I can certainly share with you my approach to dealing with lower eyelid retraction after cosmetic eyelid surgery. A little bit of background, I'm a board-certified cosmetic surgeon and fellowship-trained oculoplastic and facial reconstructive surgeon. I've been in practice in Manhattan and Long Island for over 20 years, and I have been well known for helping people who have complications of eyelid surgery, in particular lower eyelid retraction. In fact, patients come to our practice from around the world with exactly this issue and with many complexities, and I'll discuss with you my overall approach. So with this understanding, I'd like to help you get a sense of the anatomy that is relevant to this issue of lower eyelid retraction and whether or not and how I make the decision about the appropriateness of a skin graft. To begin with, lower eyelid surgery has always been a procedure that is actually deceptively complicated. And the reason is that traditional eyelid surgery, which is basically taught to most general plastic surgeons as the go-to operation, is the transcutaneous lower eyelid blepharoplasty. That means going from the outside, making an incision underneath the eyelashes, extending it a little bit beyond outside of the outer corner, lateral canthus, and addressing fat pockets, etc., and then taking away some skin with the desirable outcome of improving wrinkles. Very commonly, patients will have rounding of the under eye or retraction of the lower eyelid. So when we look at the structure of the lower eyelid, there are some key elements that essentially get disrupted routinely in this type of surgery that are usually not addressed in the restoration of the eyelid after the surgical procedure is completed. So there are three basic elements. One is the lateral canthal tendon, which is the tendon that holds the eyelid to the bone. Then there's an area called the posterior and middle lamella of the eyelid, which acts like pillars that support the lower eyelid. And then there's the anterior lamella, which is the skin and muscle in front of the eyelid. Now the muscle in the front of the eyelid is called the orbicularis muscle, and it acts like a hammock or a sling that keeps the eyelid in place. Now when I see what appears to be younger appearing lower eyelids, I am often challenged by the issue of placing skin grafts. When you are dealing with a younger person with eyelid retraction, I try to do everything I can to avoid the skin graft if possible. And how is that possible? Well, one of the ways I approach the eyelid is, of course, I establish by examination the elasticity of the lower eyelid. And what I'll do is I'll take the lower eyelid and I'll push it upward. If the eyelid is able to move several millimeters as close to the original position without putting tension on the skin, then we're in a position where we can probably avoid a skin graft. So what I then would do is I would do something called a posterior and middle lamellar graft, and that's putting tissue behind the eyelid to act as a support to provide vertical support to the eyelid, and then as well restore the lateral canthal tendon, or essentially resuspend and fixate, if necessary, the lateral canthal tendon, which is usually necessary in order to provide the remaining support. Now, in some scenarios, when the skin is on a little bit of there's a little bit of tension and it needs a skin graft, well, then skin graft is necessary. But what I try to do is minimize the size of the skin graft. Now, as far as the issue of the physical weight of the skin graft, it's generally not an issue. It's more about the appearance of the skin graft. And I always explain to my patients that the skin graft appearance can be very prominent in the beginning, and it can be customized and tailored to be minimally just the right amount so that you don't have to have excess. And that's part of the art, and that's part of the strategy. And once that skin is in, you can, what we do in our practice, we use a lot of different techniques, particularly in the regenerative medicine field, where we use something called PRP, or platelet-rich plasma, and acell, or extracellular matrix, which is advanced wound healing that does help facilitate the healing process of all the grafts that are involved in a lower eyelid retraction repair. And it's been quite helpful in expediting the outcome in terms of the rapidity of healing, as well as improving the aesthetic appearance. Beyond that, a skin graft can also be improved through additional PRP injections, lasers, and other modalities. So it becomes a challenge in a situation like yours to decide how much is it worth it to bring the lower eyelid up relative to the aesthetics of adding skin from the outside. It might be that getting a 1 or 2 millimeters of elevation and restoration of shape and getting you a little bit closer may be adequate. I've been impressed certainly by situations where I've put a graft on behind the eyelid and I was able to get the vertical height that I wanted. Now, in some people, I've done things to help try to stretch the skin and do things to maybe reduce the necessity of a skin graft, but that requires a physical exam in order to determine this. So, with due respect to the doctor who you saw for the skin graft, I think it's advisable for you to get additional opinions from oculofacial, plastic, and reconstructive surgeons, particularly surgeons who do a lot of revision eyelid surgery for cosmetic surgery, and get that sense of what would be right for you. It's very important that you take the right next step to minimize the number of surgeries you need. We've had patients who come to us who have had 11 operations before coming to see me, and in those situations I've actually had to do basically tissue rehabilitation to make the tissue healthy enough before I was able to do additional surgery. And that's basically, unfortunately, sometimes what happens, because a lot of different operations get done as little patchwork approaches. I'm not saying that the skin graft isn't a good definitive operation, but it may not be adequate, because when you think of the anatomy, the skin graft is really approaching the front, but what about what's happening from behind? Will that be adequate enough long term? A lot of times the eyelid can look good in the beginning, but may sag because of lack of support in the middle lamella. And so, again, this is maybe getting overly technical, but it's important to at least get a good sense of the principles. So I hope that was helpful. I wish you the best of luck, and thank you for your question.